Senthil and the Cincinnati group to have included a few of us for this workshop. This is a totally different ball game. High-grade spondylolisthesis. How do you define high-grade spondylolisthesis? We'll use the most often used Meyerding's grading of spondylolisthesis. That means dividing the L5 and plate into 4 different parts, 25%. You all know that. So you grade them from 1 to 4. More recently, optosis, spondyloptosis has been added as the grade 5th for spondylolisthesis. So it's actually the grade 1 and grade 2 which are the low grades, and the grade 3 and 4 in optosis which have been labeled as high-grade spondylolisthesis. When you look at the etiology, the type of curves, and you look at the Wilson-Newman's classification, dysplastic and the ischemic ones are the ones which go into high-grade listhesis. Degenerative spondies do not progress and they stay as grade 1, grade 2 listhesis as such. Similarly, if you look at the Marchetti classification, is the developmental type of spondies which are described as high dysplastic or low dysplastic, which really progress to become grade 3s, grade 4s, and grade 5s. Now, if you look at the pictures here, dysplastic and ischemic ones can be differentiated by looking at the posterior elements. And if you look carefully, there will be the posterior elements, the pars interarticular, as you all know, will have either some defect, either a lysis, or will have elongated pars. As compared to that, the degenerative listhesis will have an intact posterior element, intact pars, and the real instability occurs at the capsule and the facial joint, which allows it to subluxate slightly, but would not go on to high-grade listhesis. They would stop short at grade 1 or grade 2. So the high-grade listhesis are mostly dysplastic and ischemic types. It is also very, very important to look at the normal contours and the shape of the vertebra. And the dysplastic vertebrae, you'll have a dome-shaped LS1 and a wedge or a trapezoid L5. And these dysplastic ones are usually confined to L5S1, whereas the degenerative listhesis would be in L3, 4 or higher up even. Okay. And that brings us to biomechanics of the high-grade listhesis. So when there's a high-grade listhesis more than grade 3, then the center body weight, the line of body weight shifts more anteriorly. As a result of this, there's a local lumbosacral kyphosis, and the body, then the pelvis sort of tilts backwards to get your weight-bearing line back over the hip and to stabilize your spine as such. As a result of which, what happens is the pelvic rotates and the sacrum becomes very, very vertical. The hamstrings get attached to the pelvis, and so once they rotate in, the hamstrings get tightened. And that leads to what is called a crouching gait, hamstring spasm, and leads to a flexion of the knees, a flexion of the hips, and that's the classical crouching gait of a dysplastic high-grade listhesis. Also, a compensatory mechanism happens, and there is an increased lordosis above this kyphosis, which you get a lumbosacral junction. Also, what happens is because of the high-grade slip, the spine sort of protrudes forwards. There's a local pinching of the spinal canal. There's local stenosis, which is most central, as well as lateral stenosis there, and gives rise to radiculopathy, nerve root stretching, canal stenosis, and also because of the moving forward, the capsular laxity, and various other reasons, instability, there's mechanical back pain happening. So the dysplastic high grades are a totally different different types of listhesis as compared to, say, degenerative analytic type of listhesis. They classically present during adolescence like an AIS, and they come with a crouched gait, with a backache, with a leg pain, with increased hyperlordosis just above the lumbosacral kyphosis, and also it has a classical shape of the pelvis, which is called a sweetheart pelvis. The buttock starts back. It's like a like a square there, and because of the shift anteriorly, and the whole trunk seems to be telescoping inside the pelvis. And all this actually, and of course, when you examine the patient has a very, very tight hamstring, with the leading on to a crouched standing and things like that. So all this leads on to these high-grade dysplastic ones to be considered as serious deformities. I mean, we treat kyphosis of 30 degrees in tuberculosis. We are very concerned in a thoracolumbar junction. But what about this? What about a picture like this? We just do not want to treat these. So this is definitely a deformity which has to be looked into. Also, these dysplastic high-grade listhesis are different animals, if you want to call them. There's asymmetric growth, development abnormalities, and they are akin to what is in orthopedics you know as Blount's disease and stripped capital femoral epicyst. Look at the similarity there. They are all growth asymmetrical disorders really, and you have to look at them like that, and you have to treat them early, and you have to do something about that rather than sit over it and let it pass by. Also, what has now come forward, this has been brought forward by the European group, the Rusuli group, is that these are spinopelvic deformities, and this sagittal plane imbalance is happening there. So, I mean, most of us get scoped into getting a lumbosacral spine X-rays done like that. It's very, very important when you look at spondylolisthesis now to get a standing sagittal as well as an AP view X-rays done to see the sagittal balance, how the spine is balanced over the pelvis and the pelvis is balanced over the femur, and that's very, very important. And the Labelle and Risudi group has formed a spinal deformity study group which has looked at the spinopelvic parameters in adult as well as adults in deformities there. And this itself is a completely different talk. I won't go into that. But all it does, it defines these angles, the pelvic incidence, sacral slope, pelvic tilt, and then looks at the deformity in totality by standing X-rays and the spinal balance in the sagittal view. And based on that, 6 different types of deformities as spondylolisthesis has been described, the low-grade ones and the high-grade spondylolisthesis based on this STSG standing film X-rays and this. So in the low-grade ones, for example, if the pelvic incidence is very, very high, these are the ones which are likely to progress and become high-grade listhesis, as compared to the one when the pelvic incidence is normal, that is with about 45 to 60, or if they are low, then the chances of it becoming high grade becomes very, very less. So one has to look at these angles, and that's where the sagittal balance comes in. Whereas if you look at the high grade listhesis, and again I won't go into details, but just take you in a summary manner. If the pelvic incidence and the pelvic tilt is well balanced, then it's a balanced pelvis, and all that you do, even if it is a grade 3 listhesis, is to do an in situ fusion, and you'll be fine. However, if you land up in a situation where the pelvic tilt is very, very high, it would mean that your pelvis is not balanced, the spine is not balanced, in which case there is a strong case of reduction and fixation. Simplistically, these are the few inputs that you get in these classifications. And a lot of newer criteria for fixations are sort of indicated by this classification. So that brings us to the management strategies. So if you see even a low-grade dysplastic listhesis like that, we tend to treat them conservatively. But if you see that tilt is kind of a dome shape and a tendency towards the trapezoid sort of a vertebra, then you got to be very, very aware, follow them religiously, and because they are the ones which are likely to sort of progress and become high-grade listhesis, and in which case, once you see them progressing, that's an indication for surgery. High-grade listhesis more than grade 3 are now considered as indications for surgery, provided the spine is and the pelvis are very balanced, as I showed you the Lebesgue classification as such. Now, when you need to operate on them, so if your conservative management is failed and there's intractable leg pain, there's intractable leg pains and claudication and back pain, then there's an indication for surgery. So, simplistically, what are the surgical principles that you adhere to? If there's a leg pain or neurological or neurogenic claudication, then obviously you would look to decompress. And the decompression which is done in these cases are traditionally the old-fashioned, what is called a Grill's procedure. There's a loose fragment in the L5 lamina, and that is removed simplistically, and that's called an opiculectomy, or a rattler as it is called, is removed. And that exposes your spinal canal, and it also exposes your root, your L5 root and S1 root. So you need to do a good decompression. For back pain, which is usually due to the instability, you need to fuse that, right? Now, if instrumentation is added, it corrects your deformity and it improves the fusion rate as such. Now, the real controversy in treatment of high-grade listhesis is the type of fusion that you give. All of them would need decompression because there's significant leg pain. So you want to do an in situ fusion or reduction and fixation. These are the two issues that you have, and there's a lot of controversy on that. So in situ fusion is what we all earlier, before 90s and 80s, were all doing. A Gill's procedure, wide laminectomy, and an intertransverse fusion for prevention of further slip or treatment of the instability is what you'd get. And often you'd get a very, very good fusion solid mass in the intertransverse process. Some people even did a rotation flap with the muscle intact and got the fusion. Even these in high-grade listhesis, solid fusion like this, 30% of them would further progress. That has been shown. And the pseudoarthrosis rate was very high, about 30%. And then came the different instrumentation which is used. So we did, even we used a lot of these heart cell wires in rectangles and even for listhesis. And you see the good fusion that is received there, good solid fusion, and it worked. More recently now we've started using pedicular screws. And one of the good techniques to use in a high-grade listhesis is what is called a delta fixation. You do a Gill's procedure, and L5 pedicle is very, very low down, and often miss it. So fix your L4 and go into S1 and go obliquely in, and you'll hit the L5 one. In fact, the delta fixation was first described as a default sort of a technique. The surgeon was trying to fix S1 and got into L5 S1, and that worked. It's now a fairly reasonably well established technique after decompression to do an in situ fixation. So the dictum is, if your spine and your pelvis and your spine is balanced over the high grade listhesis, then you can go ahead and do a delta fixation with decompression for your red place. However, these in situ fixations would not correct your deformity, and I said in the beginning that these are serious deformities. You got to look at the lumbosacral kyphosis, the crouched gait, and the bending backwards of the spine as such. And for this correction of deformity, you need instrumentation, you need to reduce and fix these, and also to restore your sagittal balance there. Okay. With reduction and fixation, the crouched position is reduced to a great extent. The local kyphosis is reduced, and the reason for that is that once you tilt your pelvis backwards, when you compress your L5 and S1, then your vertical sacrum then tilts back, and you get your crouched position. The crouched position and gait is restored through. Of course, it stops progression. It gives you higher union rate, and also when you're trying to fix them, you'll be able to do a very, very good decompression also. But why is not been popular? The part of it is against reduction and fixation is that it's technically very, very demanding. And if you look at the 80 figures there, and these are all big names there, people who have been reducing and fixing, very high incidence of neurological deficits and foot drops, 80 to 30%. However, having said that, now as we got technically more advanced and we're able to do a wider decompression, it's very important that you decompress, see the nerve root right up to the exit, very laterally. Look at L5, look at the S1 roots, and then they bring in your better instrumentations, which let you correct your deformity, and you slip gradually. And you, as was said earlier, also for the scoliosis rigid deformities, you need to change your rods a couple of times, so gradually reduce it. You can use reduction screws or different reduction devices. So what is important now is that you have these monitors which let you monitor your nerve root when you're manipulating it. The intraoperative EMG and SSEP will let you know how much you're stressing your S1, L5 root, and so you can stop and work accordingly. So the incidence of foot drop and neurological deficits has dramatically reduced. And there's evidence there that there's meta-analysis of all the articles which looked at reduction and also in situ fusion for high-grade listhesis. And if you look at the blue area, we looked at the neurology. R is the reduction group, and IS is the in situ fusion. Now, if you look at the lower line there, the incidence of foot drop has reduced dramatically. 1 foot drop, and transient foot drops. However, what is interesting is even in the upper group, the in situ fusion groups, there are still reported foot drops there, right? But there is a definite advantage when you reduce and fix. You get a definite significant higher fusion rates. Now, what was controversial is the outcome. So the outcome in terms of satisfaction rate and other rates are actually exactly the similar whether you reduce or you do an in situ fusion. Just to look into this controversy, the Spine journal and the SRS set up a committee, a study group, and look at the names up there: James Ogilvy, Haile Schaffelberger, Paul McAfee, all very aggressive surgeons. Yet you had Gunnar Anderson, Todd Elbert. These are more relatively more conservative surgeons. So both the groups were fairly well represented. And Gunnar Anderson is the evidence-based medical guys. And look at the statement that was published in Spine in 2005. And they say in patients with high-grade listhesis, there's compelling rationale to reduce and realign the spondylolisthesis deformity, thus restoring the global balance. But they also said the decision has to be very, very individualized. So if your surgeon is skillful and has the infrastructure, has monitoring other things, then there are definite advantages of fixing and reducing these deformities as such. And it's a strong consideration, particularly in pediatric patients. And what they also said was that circumferential or global fusion with the instrumentation is the ideal way to go about it. So there is your evidence that there is a rationale to reduce and realign these deformities. Our own experience, we have been doing it since late 90s, 24 patients. Good many of them are in the younger age group, but some of them come late with very severe leg pain, and in 38 in the middle age group also, and they need to be treated. Well, we do a wide decompression, a Gills procedure. And what we do is we use the Jurgen-Harms technique. We go to L4 and L5 and S1 fixation, and we use reduction screws. You can use any reduction devices, and there are lots in the market, very sophisticated devices. Basically, two maneuvers are done. Basically, you distract by pulling L4 and S1. So a distraction force is applied. Some people even go up to L1 to get a distraction with an outrigger, Harrington outrigger, as was shown by Viral. You use a Harrington outrigger, distract it, and the next maneuver is to bring your L5 up towards the L5 with the S1. And that is done by various reduction devices, that is reduction screws or the tall Eiffel towers to reduce it whichever way you want it. But the crux of this is all the two nerve roots should always be visible to you. This L5 monitoring should be done, and you should reduce it very, very gradually, and then you'll be relatively safer. One of our earlier cases, often these dysplastic ones, the dome besides putting the spine into a sagittal alignment, It also, because of the dome, there's a shift of L5 in the coronal plane. So a lot of these patients land up with a scoliosis. And when you correct the L5 S1 by reduction, you correct the scoliosis automatically with a shortened fusion. This was an older case, and we did a reduction all from the back, and we did an intertransverse fusion in this. We now do an interbody fusion routinely. The ones which present late, I mean, these dysplastic listhesis have occurred in adolescent, and just like scoliosis, but they may present at a later age group, 20, 25 age group. Then they become like our AIS, they become very, very rigid. In which case, we adopt a slightly different approach. We do an anterior release. Now, if you see the dome, which you see at S1, is easier to knock out from the back, but the wedge-shaped vertebra L5 you cannot knock out from the back, so it's easier to knock that out and release anteriorly. So we first would go anteriorly and do a partial excision of the L5 wedged vertebra, and come back at the same sitting or a stage sitting, put the rods in, put our screws in L4, L5, S1, knock off the dome from the back, which is easier to do, and then gradually pull it back into position and do an interbody fusion of L5, S1. That's the technique which we follow and has been done in cases like these. We gradually reduce them. An anterior partial resection of L5, doing a retroperitoneal approach, and then posteriorly go and reduce it gradually and fix them up. Also, it is important that once you reduce it, you also you sort of decrease your lumbosacral kyphosis, and long-term follow-up gives good results. You restore the spinal, the sagittal balance also. This girl is now about 15, 20 year follow-up, and you see we've been able to reduce them well, and she's held on for 10 years follow-up. These are 5 years follow-up, good fusion. And look at the shape of the back that has been restored to. That's very, very important. The local deformity is taken care of. Also, in the long run, you see that the sagittal balance has been restored to, as you see in these spiral CT, sagittal balance. And it's very obvious if you look at the soft tissue there that the local lumbosacral kyphosis has been corrected as such. And of course, your sagittal balance, which is now so much talked about, is restored, and your spine is well balanced with your pelvis as well as your hips. Now, the ones where the spine is relatively balanced, but the pelvis is not, and by just doing from the back and sort of mobilizing it all around and instrumenting it, you'd be able to, even if you have got a partial correction, you'll be able to correct and align and restore the balance there, reducing the sacral slope, reducing the pelvic tilt. Your pelvic incidence would be the same, and you'll get a fairly decent result like that. And you see that the crouch gait here, even if they haven't achieved a complete correction, is totally relieved, and the patient, of course, does well. And when we looked at our outcomes, we had a very good fusion rate of these high-grade listhesis and good functional status. I won't worry, but if you look at the complication rate, we had 2 L5 weaknesses there. One of them recovered. That was picked up during surgery by the monitoring, but one did not. This was before we started using our nerve monitoring in early 1990s. And if you look at the newer studies of people who are reducing and fixing, the Guggenheim, Shuffleberger, Molinari, Keith Breedville, they all say that they are able to reduce significantly the slip angle and slip percentage. Also, good fusion rate has been achieved, and relatively much less neurological deficit as such. Now, that is the very popular, very well-known procedure, the Gaines procedure for high-grade listhesis and optosis. And besides Bob Gaines, not many people use it. I don't use it. The concept is to remove the L5 vertebra completely from the front and then go back, remove the posterior elements of L5 from the back, cut the dome back, and then fuse L4 to S1, bone-on-bone concept of Bob Gaines, but very morbid surgery, and I personally don't have any experience of that. So in summary, high-grade listhesis has to be considered very separately from the degenerative listhesis, from the lytic listhesis, and as was summed by the SRS and the study group of spine, the type of surgery should be very, very individualized. So if you have the expertise, if you have the means, only then and the experience, then go in for these kind of reduction and fixation. Otherwise, it's a good option to do an in situ fixation with a wide decompression. Delta fixation would get you a fairly good fusion and would be able to sort of prevent your further slip. But of course, reduction fixation has its own advantages. Correction deformity, restoring spinal balance, and neurological deficits. The rates were very, very high about 20 years back. Has been reduced now to 5% or less. Having said that, it still is a case. There is a case of this. It's a dangerous surgery. L5 and foot drop is a major complication, and one has to be aware of it. Thank you for your kind attention.
Any questions? So if you're going to be doing a reduction, is that always an indication for anterior column support in smaller children if you have an 11 or 12-year-old?
Yeah, nowadays it's absolutely must that you do an anterior column support. Either go interiorly and do it, or you do a T-lift sort of an approach and do an interbody fusion like a T-lift. What it also does is that if you do for example, what I would prefer to do is by doing preparation for the interbody fusion, you remove the disc, you remove the fibrous tissue all around, so you're actually loosening up the fixed L5 S1 where the slip is, and you've cut the facet already in. So you loosen up your deformity, and then you can pull it back more comfortably. Sorry, I couldn't get your question here.
Does the presence of S1, S2,
S1?
S1, S2, well-developed disc affect your treatment plan? Do you go distally?
Oh yeah, you mean when do I use S2 as a fixation device?
Yes.
Yeah, in one of the in the rigid types, in very rigid, I'll just show you. The paucity of time, I'll just cut that out. In very rigid curves, and in very young patients, right? In this particular patient has a scoliosis too. Then we use an S2 also, and I use an S2 lateral screw to supplement. I don't like, a lot of these American surgeons, and particularly Shufflebarger and all, they like to go into the ileum in adolescent young patients. I somehow, even if you're not jeopardizing the joint, I somehow feel very, very sentimental about crossing a virginal 10-year-old SI joint and then going into the pelvis. So I would much rather, if I need to fix, I'll use an S2 fixation. It's different in an adult where you can cross your SI joints and go into the pelvis. But with young children, I feel a bit sentimental about that.
Arun, we have the additional problem of the screw head becoming very, very prominent.
Very prominent,
at the S2 area. There are a few times that we use. Now we more or less gave up.
No, but now there are techniques to bypass that. You cut a portion of the posterior segment. But then again, I mean, when you cut that posterior portion of the iliac crest, there's epiphysis there. You don't want to cut that in a young girl, you know.
They become very prominent in our children. They're very small. And then the screw head is so big at the S2 level on the skin.
So one another question. The problem of reduction, one is the neurological deficit. The other one, literature says that the adjacent segment degeneration is very common when reduction is done. Your comments about that? The literature says that it's a more quicker degeneration occurs proximally.
Yeah, but like what was talked about in the morning, as long as about scoliosis, that adjacent level degeneration, how effective is that? Studies have shown overall it does not really matter. Now, adjacent level disease and degeneration has come into picture in degenerative disorders. there the adjacent level is already jeopardized, but by fixing either in scoliosis, AIS, or in young adult kids, I mean, there's not much evidence to say that the degeneration really occurs. I mean, I don't believe in that. And there are evidence, like it was nicely shown by Viral, that, adjacent level does not occur even if you fix up L4, that lower level does not make a difference actually. So how much does that contribute clinically, we would not really know.
Suresh? Yeah. I think your topic is next. Can you get ready for that?
Yeah.
One more question. Do you go always up to L4 or you fix L5 S1?
No, in the younger children, if they're grade 3 or grade 3 plus, not 4 in optosis. 4 in optosis, I'll definitely go to L4. If there's lesser and the younger children, if I'm able to reduce them very comfortably all from the back, then what I would do is what Jagannath does, fixes L4, L5, S1, and then 4 months later you just go in and cut the rod out and remove the L4, so it becomes a monosegmental fixation. Of course, when you're fixing all these up, we would try not to destroy the capsule and the facets of L4. So some of them are like that.
Go ahead.
Can you take the mic, please?
Based on your classification of, Dr. Labella, you tell us about the high grade of number 5 and 6. Do you do any surgery differently between that type 5 and type 6 in terms of correction?
Most of the surgeons who have been doing this have not really looked at that classification. Russoli's classification is a retrospective analysis of the patients.
So
they looked at the cases and saw how many of them were 5 and how many 6 of them. So prospectively, maybe in the next decade, this will come into prominence. But as such, most of us do not look at it. But having said that, the 5 and the 6 are the ones, the type 6 particularly, is the one which has an unbalanced pelvis and an unbalanced spine. These are the ones which have a severe deformity, which will have a very severe compromised hamstring tightness and a gait deformity, and these need to be reduced and relieved, definite indications. Whereas grade 4 is the one where the spine is well balanced over the pelvis and the pelvis is not so much retroverted, in which case you can just do an in situ fusion and do a decompression along with it.
And 5? What will you do if you have a type 5?
A 5?
Yeah.
5 is again a gray area. Some people would say just do a in situ fusion, because even if the spine is balanced, the pelvis is retroverted. So that would give rise to, and I showed one of the cases which was 5, and I could not sort of do a complete reduction. The reason for that, it was a young male, and I did not want to go anteriorly because of retro ejaculation, so I just did posterior. I partially corrected it, even then the patient recovered, his crouching gait recovered. Okay.
Thank you.
Thank you.
Thank you very much. Dr. Suresh Pillai.
Good afternoon. Spoken. See, this young lady, the stance of the young lady, she has all the compensatory mechanisms for a sagittal imbalance. Flexed knee, hyperextended hip, a flat back, and a hyperlordotic spine above. What went wrong with her? Actually, in her teenage, she underwent an in situ fusion for this grade 4 listhesis without instrumentation, and that was the compensatory mechanisms she had after that. So the characteristic of this high grade listhesis is the rotation of L5 around the sacrum. So when the L5 along with the spine moves forward, the there will be compensatory mechanisms like flexion of the knees, hyperextension of the hip, hyperlordotic spine above, so that the center of gravity line is kept in between the legs to the ground. So that's what happened with her. So the role of spine, as you know, is to protect the spinal cord as well as the nerves, then allow the movement of the torso above, as well as carry the weight of the body down to the legs and to the ground. When the spine is loaded in the upright position, there are a lot of forces acting at the lumbosacral junction. There is shear forces, and the magnitude of these, the imbalance of these forces, determine the development of high grade or spondylolisthesis. Also, the magnitude of this anterior force is affected by the inclination of the sacrum from the horizontal. So, depending on the imbalance in the forces over the lumbosacral junction, there are two theories put forward for the development of spondylolisthesis. That's one is the slip theory. That is, the weight of the body acting through L5 sets the stage for further slippage of L5 over S1. And the second is the pelvic retroversion theory, where the pelvis goes back, then the iliacus and psoas pulls the body along with the spine forwards. And when the spine is loaded in this position, about 75% of the load is borne by the anterior aspect of the spine and only 25% in the posterior elements. You know, the spondylolisthesis, there is deficient L5S1 laminae as well as degeneration of the disc. When the disc is damaged, there is a lot of dynamic forces, increase in forces acting at the lumbosacral junction, as well as the facetal loading also become much more. So the crux of treatment of spondylolisthesis, an anterior strut as well as a posterior tension band. So a reduction and a fixation and interbody fusion is the correct method of treatment for spondylolisthesis. So there are different classification systems as already mentioned. And to know when should we treat, we should know what are the predictors of progression. Clinically, younger age, female sex, and persistent clinical symptoms, they warrant treatment. And radiographically, there are dysplastic listhesis like facet tropism, deficient L5S1 laminae, elongation of the pars, rounded dome of sacrum, trapezoid L5, short transverse of L5, dysplastic facets. And increase in pelvic incidence, increase in slip, dynamic instability, degree of slip more than 50%, slip angle more than 30 degrees, increased lumbar lordosis and signs of sacral root stretch. All these are indications for treatment. The angular relationship between the L5 and S1 is most important than translational alignment. So it's better always, if there is a angular relation between the two, the chance of progression is much high. So you need to do an interbody fusion than a posterolateral fusion, much safer. So the treatment options, we rarely offer surgery for asymptomatic grade 1 or 2 low dysplastic variety of listhesis. But when they present you, they can give anti-lordotic brace, physical therapy, hamstring and abdominal muscle strengthening, and avoiding hyperextension exercises. But when surgery is considered, if there is persistent symptoms, failure of conservative treatment, radiculopathy, gait abnormality, hamstring spasms, and high-grade listhesis, and patients with neurological symptoms. So, low dysplastic, if it is persistently symptomatic, you can go for a in situ fusion with posterolateral fusion. But if there is an angular relationship between the orthostatic vertebrae, then you need to do an interbody fusion. So in high-grade listhesis, you can go for a circumferential fusion, the reduction by anterior release, as Professor Jaiswal has mentioned, then posterior only release or sacral dome osteotomy, all these. So here is an example. This is a grade 4 listhesis in a 63-year-old lady with the persistent symptoms, then all posterior, reduction to grade 1 and in circumferential fusion. She has been doing well. So almost 10 years now. And the advantages of reduction, everything is mentioned. Increases the fusion surface, correct the spinal deformity, and gait of the patient, as I showed in the initial picture, her stance was, and labored gait was secondary to the sagittal imbalance. So with a reduction, you get a normal gait and a posture and cosmetic appearance. Here is a 38-year-old. She came to me with grade 4 listhesis. I offered her surgery, but she was reluctant at that time. Then after 2 years, she came to me with a further slippage, difficulty in walking, and wheelchair bound. This is her MRI showing the listhesis. So I did all posterior, do a sacral dome osteotomy, and then reduced and did a circumferential fusion. She has been doing quite well for last 4 years now. Here is another with see the angular relationship between the L5 and S1. It's also reduced and did a circumferential fusion. And here is another variety with elongated pause. There is a 22-year-old lady postpartum. She had persistent symptoms. This elongated pause also reduced and did a circumferential fusion. Most of the lytic listhesis occur in the L5S1, but they can occur in the other levels also. Here is an L4-5 lytic listhesis. It's a double level listhesis with lytic listhesis in L3-4 as well as L4-5, all double level interbody fusions. It's a low grade listhesis with the persistent symptoms, and she was treated with the shunt screw reduction technique of AO, then instrumented fusion with the complete reduction. And here is two level listhesis L4, 5 and L5S1 in 27-year-old. That was in 2004, now 9 years. This is the butterfly fragment. I removed it en masse. And then two level PLIF. She has been doing well and for now 9 years now. And a few words about spondylottosis. Gaines procedure as already mentioned. You can do a complete vertebrectomy and reduction of L4 to S1, or in a skeletally mature patient you can go for a transsacral fibular fixation. Like this, between S1 and S2 nerve roots, you can go in perpendicularly down to the L5. Here is an example. This is a spondylottosis with bilateral feet drop, decompressed and did a transsacral fibular fixation. The fibula is marked there. He has been doing well. And the rate of fusion is uninstrumented, it is 55%, and posterior fusion with implants is 71%, and circumferential fusion, the literature say there is 100% fusion for that. And degenerative listhesis, another type of listhesis. If there is no angular relations, as I mentioned, you can go for a simple posterolateral fusion, in situ fusion and decompression. But if there is angular relations, better to do interbody fusion. And traumatic listhesis, mostly here the facet gets fractured than the pars. Here is an example of a high velocity trauma, road traffic accident with the spondylottosis, and his entire spine, the L4, L5 spinous process, everything was shattered, all the muscles, everything was torn off. So need urgent reduction and fixation. This X-ray is at 4 years post-surgery, and now it is 8 years now. He has been doing well, except a FHL weakness on one side. Otherwise, he is absolutely doing fine. And usually the degenerative listhesis don't worsen unless intervened. If there is a direct laminectomy without fixation, they go for further progression. If there is an indirect adjacent level, then you can manage conservatively. If it's a direct listhesis, then you need to do an interbody fusion. Here is an example. Somebody did a laminectomy without instrumentation. They did without instrumentation, they did a fusion, but it didn't work. It progressed and became angulated. She needed reduction and the circumferential fusion. Pathological listhesis usually the symptoms are related to the pathology, not to the listhesis. And everything has its own toll, and maybe immediate surgical or anesthetic and late pseudarthrosis or screw breakage, everything. So if there is a high grade listhesis, it's better to reduce, and there is mind the angular relationship between the vertebrae, and they do well. Thank you.
Any questions?
Meanwhile, can we ask Dr. Marius Likisas to kindly start getting ready for the presentation, please?
Partial reduction of the advantages of reduction we have already mentioned. Increases the fusion area, then sagittal profile, everything is improved. I have shown you the initial picture of the lady walking with just like an very old man, or clumsy gait, labored gait. So if you correct the sagittal profile, then the hamstring tightness, the increased work needed for the gait, everything will be avoided. So as much as possible reduce.
Which stage are you talking about? Grade 1, grade 2, grade 4 or 5? So the question is very clear. Grade 4 or 5?
If
what is, one second.
There are different.
Suresh, what is your take home message?
Yes.
What should he do?
Yes.
Yeah.
I have shown you the spondylothosis in an old man with feet drop. Then I did a transsacral fibrillar fixation. He has been doing well. And others, I have shown you the reduced and fixed over from behind. But if you can reduce it, it's better to reduce always. But if not possible or other constraints, then you can do an in situ fixation.
Arvind, what's your advice for a young surgeon? You know, we are not.
He was very honest about
Yeah.
it. He does not have the experience of absolutely.
Yeah.
You don't have a needle monitoring device. You have a high orthosis there. The best way is to the patient would be having leg pain, would be having medication. So, and it is then in that case, all that you do to do a wide laminectomy, decompress it, and do an in situ fusion. Right? But if you're having a young girl, a 14-year-old girl with grade 4 disease, my advice and the take-home message should be that that's a different set of, it's a totally different sort of a ball game. An ordinary regular orthopedic surgeon would not do a scoliosis correction. Would you do a scoliosis correction? No. So why do you want to treat this patient? Send it to your colleague who does it. Right? This is a specialized tool as compared to degenerative diseases or an adult lytic disease with grade 2, grade 3. Do a postural reduction, fix it will be okay. But treat them like you would treat a scoliosis patient. You don't have experience, send it to a center.
Yeah, I think that should be the take-home message. You know, the complication rates going up to 25% in various series. This is much more dangerous than an idiopathic scoliosis, grade 4 and 5. That should never be your cup of tea. I think, as Arvind says, you should take him to the nearest spine surgeon who is capable and experienced enough to doing this, and you should go observe what he's doing, and then you'll get an idea.
And recognize it. No?
Right.
Not that I'm doing in situ fusion in a 12-year-old or 13-year-old. Don't do it, because in idiopathic scoliosis, as of now today, you will not do it, right? So use these as the same thing. The problem with us is that we continue to do a intertransverse fusion with the laminating, high thinking, then regular spondylosis.
Thanks. Thank you, Suresh. We'll move on to the next topic. Lateral lumbar interbody fusion, surgical technique and complications. Marius.
Thank you. I would like to thank the Indian Orthopedic Association and, of course, Professor Stern and Dr. Senthiel for the invitation to participate in this excellent meeting. So, as you may already know, lateral lumbar interbody fusion is the minimally invasive direct lateral retroperitoneal transpsoas approach for lumbar interbody fusion that has been developed as an alternative to the well-established anterior lumbar interbody fusion. Compared with previous methods of lumbar interbody fusion, it is said to be associated with improved graft-host interface, higher fusion rates, improved restoration of the spinal alignment, better foraminal decompression by achieving greater correction of the intervertebral and foraminal high, decreased blood loss, early patient mobilization, and decreased hospital stay. The major advantage of ELIF over placebo is the insertion of wider implants that span the dense ring apophysis and provide excellent mechanical support to resist subsidence and maintain the body high. Its indications include disc degenerative disease, adjustment degeneration, degenerative spondylolisthesis, low-grade spondylolisthesis, mild to moderate foraminal stenosis, as well as combinations of these entities. In general, patients who present with axial low back pain without severe central canal stenosis are considered candidates for the procedure if they failed at least 6 months of conservative management. Contraindications include severe central canal stenosis, significant rotatory scoliosis, or moderate to severe spondylolisthesis. The most important step for a successful outcome is proper patient positioning on the operating table. The patient is placed in a lateral decubitus position with the hips and knees flexed, and the table is bent on the level of the greater trochanter in order to increase the distance between the iliac crest and the rib cage. The true lateral decubitus position is confirmed by AP and lateral fluoroscopy, and the operating levels are marked. At this point, I need to emphasize that in case of inadequate patient placement on the operating table, the cage can be easily inserted in a wrong anterior to posterior direction, or in the worst scenario, an iatrogenic injury to the lumbar plexus, the large abdominal vessels, or even the viscera may occur during dissection. So after prepping and draping, a small oblique skin incision is made at the center of the pre-marked levels. Usually a 5 centimeter incision is enough in order to approach 2 to 4 lumbar levels, as in this case, in which the L2 to L4 levels were fused through a incision. First, describe the use of the accessory posterior portal at the border between the erector muscles and the abdominal obliques, and the insertion of the surgeon's finger anteriorly through the muscle layers in order to identify the retroperitoneal space and guide the dilator from the direct lateral position to the psoas muscle. Personally, I prefer the dissection of the internal and external obliques under direct visualization. So after the incision of the transversalis fascia, the presence of the retroperitoneal fat and the psoas muscle confirm the retroperitoneal access. A K-wire and a lateral fluoroscopic image are used in order to identify the mid-position of the lumbar disc. A traumatic and portal follows, as you can see in these images. At this point, an EMG monitoring system is always used in order to assess the close proximity of the lumbar nerve roots to the retractor. Experiments have suggested that threshold values greater than 10 milliamperes indicate a distance that provides both nerve root safety and ample working space. After safely securing of the retractor to the operating table, we the bony end plates, especially in osteoporotic patients. Successful removal of the disc is followed by release of the contralateral in order to provide enough space for wide dense. The case height, depth, and length are measured with trials. The cage is filled with BMP2 or DPM and is inserted using a special device that secures bone graft substitute during case placement. Cage insertion should be always performed under fluoroscopic guidance. According to a recent meta-analysis of the literature, the vast majority of the patients who underwent lateral lumbar interbody fusion reported improved better in the ODIs. Our results in radiographic fusion assessment in patients who underwent salon procedure, fusion rate 80% follow period. This fusion rate to the use of BMP2, which according to our findings is responsible for both higher and faster fusion rates compared with iliac crest bone graft or cancellous allograft without increasing the Although ELIF has been effectively used in the setting of many adult degenerative disorders, concerns remain about its safety regarding injury to the lumbar plexus as it travels the surface. Nerve injuries after 0.4%, and according to our recent 990 levels treated with ELIF, immediately after surgery, 38% of the patients reported anterior tire groin pain, while motor and sensory deficits were reported in 24 and 38% of the patients respectively. At the last follow-up, persistent motor and sensory deficits were recorded in 2.3 and 9.6% of the patients respectively, while persistent anterior tire groin pain was present in 5.8% of the patients who underwent lateral lumbar interbody fusion. The risk factors for the development of postoperative neural deficits in patients who underwent ELIF included female gender, limited previous surgical experience to the lateral approach to the lumbar spine, fusion of the L4-5 level, and fusion of multiple levels at the same setting. In the same study, we noticed a significant association between the use of BMP2 and the number of patients suffering from persistent motor deficits at the last follow-up. In order to further investigate the effect of BMP2 on neurological outcomes in this patient population, a total of 451 patients who underwent ELIF between 2006 and 2012 were divided into two groups based on the use or not of BMP2. Matching for any possible factor that may have affected nerve injury and recovery, including length of follow-up, patient's age, gender, weight, BMI, total lumbar or spinal segments treated, specific levels treated, standalone procedure site of approach and operative time, resulted in a total of 72 patients and a total of 147 levels treated per group. Immediately after surgery, a sensory deficit was recorded in 33 patients in the BMP2 group and 35 patients in the autograft or allograft group. At the last follow-up, a persistent sensory deficit was identified in 29 patients who underwent ELIF supplemented by BMP2, compared with 20 patients in whom autograft or allograft was used. Although this difference was found to be insignificant, a trend towards increased persistent sensory deficits was recorded in patients exposed to BMP2. When we evaluated for postoperative motor deficits, things were more clear, with a significantly higher number of patients exposed to BMP2 suffering from persistent motor deficits at the 6-month follow-up visit and the last follow-up. More impressively, postoperative pain was found to be present in a significantly higher number of patients exposed to BMP2 in the immediate postoperative period, the 6-month follow-up visit, and the last follow-up. It is also worth mentioning that during the last follow-up, none of the patients treated with iliac crest bone graft or cancellous allograft had pain, compared with 12% of the patients exposed to BMP2 who were complaining of persistent anterior tire groin pain. Less common complications after ELIF include abdominal wall hernia, postoperative hematoma, psoas muscle seroma formation, which has been associated with the use of BMP2, end plate fracture during aggressive discectomy in osteoporotic patients, vertebral body subsidence and subsequent loss of the interbody high, and recurrence of the spinal deformity of the stenosis, fracture of the osteophyte during release of the contralateral annulus which in rare cases may result in contralateral nerve root compression, rupture of the segmental artery during L4-5, during access of the L4-5 segment, secondary to the cephalate migration of the retractor because of the presence of the iliac crest, and iatrogenic disc herniation during when the cage insertion is performed in a wrong anterior to posterior or anterolateral direction secondary to inadequate patient positioning on the operating table. Finally, rare complications after ALIF include fracture of the implant during its position and implant malpositioning or implant migration secondary to inadequate surgical technique. The latter may result in cage insertion into the spinal canal or even the foramina, as in this case, which were referred to us for revision surgery. So in summary, ALIF combines the biomechanical and biologic benefits of ALIF with the advantages of any minimally invasive procedure. The majority of the neural deficits and pain after ALIF are transient, with persistent motor and sensory deficits occurring in 2.3 and 9.6 of the patients respectively, and persistent anterior tire groin pain in 5.8% of the patients. Unfortunately, neuromonitoring systems cannot detect sensory changes or ischemia-related motor deficits during ALIF. The risk factors for the development of postoperative neural deficits in patients undergoing ALIF include fusion of the L4-5 level, treatment of more than 2 levels at the same setting, and PMPT use. Finally, proper patient positioning, close inspection of the surgical field, and awareness of pressure from the retractor to the neural structures may reduce the occurrence of neurologic deficits in this patient population. Thank you for your attention.
Marius, thank you. Any questions?
So we are all driven by this technique, but we don't have the technology made available by the Indian FDA yet. So what are your thoughts on trying to do this without the lumbar stimulator?
Okay.
Doing a semi-open kind of an approach.
Yes.
Is that a possibility, or should we just wait till
I think you need to wait, because in many cases, although you can see the nerve roots, you can see the genitofemoral nerves when you dissect, and you're very careful when you go down to the, when you see the disc space, in many cases, big nerve roots are